Hotbed Talk.
Professor Denny Levett, who I think we all know. She's a Professor of Perioperative Medicine and Critical Care at University of Southampton, and a clinician at Southampton Hospital as well, and she's going to talk to us about the upcoming INSPIRE trial.
Thank you, David. So it gives me great pleasure today to talk to you about INSPIRE. This is a pragmatic prehab trial that's recently been funded by the HTA and that we hope to start recruiting later this year. I'd first just like to acknowledge my co-investigators. It's a multidisciplinary team, as you can see, from several centres across the UK, including perioperative physicians, anaesthetists, intensivists, surgeons, physiotherapists, and exercise physiologists. So I'd first like to address the healthcare challenge that this trial, in fact, addresses. Postoperative pulmonary complications are very common. Their incidence varies depending on your definition and which particular cohort surgically you're looking at, but somewhere between 5 and 40% of our patients experience a post-op pulmonary complication. And not only are they common, but they have very significant impact on our patients' surgical outcomes, both in the short term and in the long term. And this is just a summary of some cohort studies looking at the incidence of morbidity and mortality by whether or not you had a post-op pulmonary complication. And as you can see, mortality rates are several-fold higher in those groups with post-op pulmonary complications. So they're common, they have major impact for patients, and they have major costs, not just in terms of patient harm, but also in terms of economic impact on the healthcare system. So this is a very large cohort study from the States, from Lee Fleischer's group, and they looked at the incidence of post-op pulmonary complications. And as you can see, there are a great deal more common than cardiac complications. And having a single post-op pulmonary complication increases the financial cost of your inpatient stay by just over $25,000. So how then do we identify the patient who's particularly at risk of these complications? There are obviously patient factors, such as underlying lung disease, but also surgical factors. The risk associated with an esophagectomy is very different from one associated with peripheral surgery on an ankle, for example. About 9 years ago, some clinicians in Catalonia initially performed a large prospective cohort study with a mixed surgical group to try and identify those factors which make your patient most at risk of complications, both from the surgical side and from the patient side. And they came up with the ARISCAT score. And this score, as you can see, has 4 patient factors that they identified were associated with an increased risk of complications, and 3 procedural factors, where the incision was, how long the surgery was, and whether it was emergency or not. And you can see the risks of the different groups down here on the right. This has subsequently been validated prospectively in a 5,500 patient cohort from across Europe. So we're pretty confident that the ARISCAT score will identify a patient whose risk of a pulmonary complication is high. Pressing the wrong button. The next challenge I would suggest is, how do you measure post-op pulmonary complications? The first slide was a giveaway. If the incidence varies from 5 to 40%, and that's not all about the patient types, it probably comes down to how you define your PPCs. A lot of people use composite measures. The advantage of a composite measure from a research perspective is it allows you to reduce your sample size because you have a higher incidence of your primary outcome. That makes sense if the types of pulmonary complication occur with equal frequency and they have a similar underlying mechanism or biology. And so in 2015, the ESICM and ESA together looked across studies to try and identify the best validated post-op pulmonary complication measure, the EBPOM consensus this is, and this is the PPC measure that they used. Importantly, in terms of the INSPIRE trial, it is also the PPC measure that was used to derive the ARISCAT score. So using this outcome measure and the ARISCAT score, we have a reasonable level of confidence in being able to predict the incidence of pulmonary complications in a cohort going forward. So that's the background and the healthcare challenge. What is INSPIRE about? It's about inspiratory muscle training. What is inspiratory muscle training is the first question. Essentially, it is exercise training for your inspiratory muscles. And what the patients are given is a device, you can see here. It's a handheld device they can take home with them, which is a great advantage. They can do this while sitting at home on a sofa, so they don't have to get out. And so that's actually clearly easy. If it works, it would be incredibly advantageous to use it. When you describe an exercise intervention, it's really important to describe what you're doing, whether this is for skeletal muscles in the respiratory system or for whole body exercise. And the FIT principles are the best ways to describe exercise interventions. So first of all, how frequently are you going to have to do the intervention? We'll be asking the patients to do 30 breaths twice a day. It takes up to 15 minutes to do 30 breaths. What's the intensity of this intervention? It's moderate to high intensity exercise training. We are asking them to start at something called 50% of the MIP. The MIP is basically the highest load which a patient can inspire against. So inspiratory muscle training is about breathing in against a resistance. From previous studies, we know that you need a minimum of 2 weeks to have a significant treatment effect, and at about 6 to 8 weeks, the treatment effect seems to plateau. So it's what type of training is it? It's a resistance training. It's against an external load. And progression of that load, in the same way as progression of weights in an exercise training or progression of distance, or the resistance to the pedals in Sandy's exercise training program, is a really key element of this intervention. If you don't progress the load, you won't have a training effect for the patient. So does this work? Does the patient need to engage in this activity? So the reason the HTA have funded this trial is that there is a lot of evidence of efficacy. There is less evidence of effectiveness, i.e. its implementation in clinical practice. This is one of the recent systematic reviews. There's also a Cochrane review. This was published in 2018, looking at the effectiveness of inspiratory muscle training to reduce PPCs. The forest plot you can see here, and this is very consistent across all the systematic reviews, and this study looked at thoracic surgery, abdominal surgery, and cardiac surgery. Across these studies, which are all single-centre and small studies, so be aware of that, small studies in single centres tend to, on average, overestimate treatment effect. But this treatment effect is massive. A 50% reduction in postoperative pulmonary complications, even if we achieved a third of that, would have a very significant impact on patient outcomes in our surgical patients. Importantly, they did some very useful sensitivity analysis in terms of planning a trial protocol or an intervention for your patients. They looked at, across all of these studies, which elements of the intervention, i.e. how long it was, which patient group, how long you did it for before surgery, how intense the training. And one of the most important elements you will see here is the amount of supervision, such that you got from a 50% reduction in pulmonary complications to no reduction in pulmonary complications if it wasn't supervised at all. Once a week seems to be sufficient from this data. What is it that we're doing at those supervision sessions? Well, essentially, it's part of it is that important element of load progression and evaluating technique. I just wanted to point out that inspiratory muscle training is not the same thing as incentive spirometry. There have been a number of trials looking at the effectiveness of incentive spirometry preoperatively to reduce postoperative pulmonary complications, and it is ineffective. So there's no evidence, there's evidence that it's not effective at reducing PPCs, either preoperatively or postoperatively. Inspiratory muscle training is a different device. It's an exercise intervention, as we said, with a low progression, and those are the elements that are probably important for its efficacy in this environment. So what are we actually going to do in the INSPIRE trial? We're going to try and evaluate the effectiveness and cost effectiveness of IMT on patients at high risk of pulmonary complications in a very broad patient cohort. We're going to be looking at patients undergoing elective surgery, but cardiac, thoracic, and intra-abdominal surgery at high risk of a PPC as defined by an ARISCAT score of more than 26. And it's a three-arm trial, IMT versus sham IMT versus usual care. What are we going to do in the intervention group? It'll be between 2 to 8 weeks of training preoperatively, and that's a pragmatic sample depending on how much time we have before surgery. They'll be doing 30 breaths twice a day at 50% of their maximum tolerable load. And we will use two types of increase in that load, one using an automatic machine, which is the new electronic devices, and one is where the patient has to increase their load based on their perception of exertion. And in the sham arm, this is to try and distinguish between placebo effect from real treatment effect from the muscle training. What the patient will have is the same device, but there will be very low resistance training, which has been shown not to affect either MIP or muscle strength in other intervention situations. What are our outcomes? Our primary outcome is post-op pulmonary complications in the first 30 days, as defined by the EBPOM composite, but we'll also be looking as individual outcome measures at all the components of that composite. We'll be looking at some physiological measures, the MIP, but importantly also looking at quality of life outcomes after surgery, length of stay, length of critical care stay, and mortality at 3 months and a year. There are some planned subgroup analyses for the trial. We'll be looking at the effect of surgical specialty. Is it more important in thoracic or cardiac or general abdominal surgery? We'll look at the severity of the risk versus the improvement with the training. We also need to, and we'll be looking at what sort of prehabilitation other exercise regimes are going on during the trial, because there is a massive uptake of prehab across the UK, and so we want to see, is IMT of benefit on top of exercise training, because there are several studies suggesting that it has an additional effect on top of whole body exercise. We'll be looking at the effect of nutritional status on the response to exercise training, because it's a very important factor. We know that some patients in exercise training programs do not improve their fitness. We suspect, given the large incidence of undiagnosed borderline nutrition or malnutrition, that at least in some of our patients that reflects that they are malnourished, and you will not have a training response if you're malnourished. We'll also be looking at physical activity status at baseline and self-efficacy and resilience, and your ability to comply with the treatment in terms of degrees of self-efficacy at baseline. And finally, an analysis looking at difference in females and males. The sample size, we're powered to detect a 5% absolute difference or a 25% risk reduction in PPCs, so we need 2,500 patients. It's quite a challenge. The first 8 months is going to be an internal pilot, and this is when we're looking at the supervision effect. So a random half of the intervention group will get an extra visit at 3 to 5 days in order to basically to assess their technique, adjust the technique if necessary, make sure they've been increasing their load effectively, and evaluate what they've done in the previous few days. There'll also be telephone support and text reminders that will be going out at the frequency of at least twice a day. That's from our PPI. Patients wanted a reminder in the morning and in the afternoon. And as I said, this additional visit. Within the trial, we will also be running a simultaneous trial within a trial, which is a quintet recruitment intervention. This is a qualitative research technique that you do during the trial by interviewing patients and research nurses and those involved in recruiting patients, and try and evaluate what are the barriers to recruiting patients, understanding why patients choose not to take part and why we're not able to get to all patients. And this has been shown previously in other large studies to improve recruitment facts going forward. So we'll be doing this early in the trial once we have an idea of our recruitment rate to try and improve things. There'll also be a health economic analysis, essentially looking at quality gained and the cost of that, and looking at health-related quality of life at baseline and at follow-up, and from the survival data. Just a very quick aside to say, I think the challenge is, having listened to the last 4 speakers, being in Southampton, I'm also involved in the Westfit study. I would suggest to all of you in the room, if you want to start doing prehabilitation, the first thing you need to do is find out exactly how your patient gets from the GP onto the operating table, map the pathway, and work out how you're going to get access to that patient early. We have surgical pathways that are longitudinal, that do not lend themselves well. They're clinician-based, in fact, largely revolving around the surgeon, and not really revolving around the patient. And it's at the moment, we get involved way too late. So you need to think about bringing that forward. And that will vary from centre to centre. So finally, INSPIRE is a pragmatic, double-blind, sham-controlled RCT. We hope it's adequately powered, it will be generalisable, and will provide some cost-effectiveness data for this intervention, which seems in small studies to be highly effective at reducing PPCs. Thank you for listening.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.